Hello, everyone. This is Cassie Lab 2 from Nanjing First Hospital. On behalf of Professor Sa Liangchen, I'm moderator Dr. Gao. The operator of this live case is Professor Junjie Zhang, Vice President of Nanjing First Hospital. Professor Zhang, please introduce your team and your case.
Okay, my dear friend, so this is Dr. Junjie Zhang from Nanjing First Hospital. In the next 1 hour, we will do a TAVI procedure for a typical BAV case with severe aortic stenosis. So let me introduce to my team. In my right side is Dr. Kong Xiangquan and Dr. Zhu Jiancheng. So today, let me introduce my case information. Can you show me the slides? Actually, this is a elderly gentleman, 85 years old gentleman. So presented with severe. Next slides, please. Presented with chest pain and also with shortness of breath for 5 years and worsen for 1 month. His comorbidity including essential hypertension and type 2 diabetes. And also there is pulmonary Swiss occupation lesions, but it has been diagnosed for 4 years. It's also stable. So clinically, it's benign. So in terms of the laboratory test, BNP is elevated, 591, and the eGFR is normal, 82 milliliter per minute. ECG shows it's atrial fibrillation with RBBB. And RV function presented is New York Heart Associate Class 3. After calculation, the syntax STS score is extremely high risk, 12.6%. Next. So this is baseline's TTE. You can see from the baseline TTE LVOT view, it's a typical. Also, a short X view, it's a typical bicuspid aortic valve with moderate calcification. Next. And this show LV motion is normal. And also you can notice the apex hypertrophic cardiomyopathy, maybe due to the severe aortic stenosis. Next. And also in the four-chamber view, you can see there is a mild mitral valve regurgitation and a mild tricuspid valve regurgitation. Next. So in conclusion, from the TT echocardiography, this is a typical bicuspid valve with a severe aortic stenosis. The mean gradient is 71 millimeter mercury, and the velocity of maximum is more than 5.4%. And also with milder mitral valve regurgitation and the mild to moderate tricuspid valve regurgitation, dilated RA and the RA, and with normal LVEF value is 68%, and the mild pulmonary hypertension. Next. So CT analysis is very important for the TAVI procedure. So you can see it's a moderate severe aortic stenosis with KLC5. And also you see there is a typical bicuspid valve, type 1 bicuspid valve. There is a cariner at the left side. And also you can see the calcium volumes is 227 millimeter tubules. It's a moderate calcified. And in terms of the aortic diameter, it's not enlarged, only 32. And the aneurysm, mean aneurysm diameter is 23. And in terms of the LVOT 5 millimeter below the aneurysm, it's also 24 millimeters. So typically, it's from the CT analysis, it's bicuspid valve aortic stenosis. Next. In terms of the coronary obstruction risk, the left coronary artery high is 17 millimeter. Right coronary artery high is 40 millimeter. In terms of the SVOV is quite large, more than 30. So I think it's a low risk for coronary obstruction during the TAVI procedure. Next. So from the CT analysis, the peripheral artery is large enough with minimal calcification at the the femoral arteries. So from this CT analysis, I think the transfemoral approach is the first choice. Next. So according to the CT analysis, so our strategy for this typical bicuspid valve aortic stenosis case is we will use a general anesthesia with a angio guidance. We will use angio guidance only, and with from the right femoral access. In terms of the valve size, according to the CT analysis, the annular siding, annular diameter is 23. So we decided to use 26. Venous A is a domestic self-expandable valve. So this is our strategy. Thank you.
Thank you for your introduction. This is a very tough case. 87-year-old gentleman suffers from symptomatic aortic stenosis, and SDS score is more than 12%, very high risk patient. CT analysis found the type 1 bicuspid aortic valve. Professor Zhang, do you think how to explain so many BAV patients are found in China?
So actually, this is a typical BAV case. In China, I think last year we total China performed more than 8,000 TAVI cases. Among these TAVI cases, I think nearly 40% of cases is bicuspid valves. So I think the main reason is compared with West country, our population of the aortic stenosis are a little younger. So maybe which can explain why BAV prevalence is high compared with the West countries.
Thank you. We all know you not only a TAVI master, you're also a PCI master. You have published the ultimate trial. There are a lot of junior cardiologists online now. Do you have any experience sharing with us about how to evaluate the risk of coronary occlusion before TAVI procedure and how to prevent coronary occlusion during procedure? Thank you.
This is a very important question. During TAVI procedure, I think the most important before the TAVI procedure is to evaluate from the CT analysis to evaluate the risk of coronary obstruction. There is three factors which will impact on the coronary obstruction, or maybe you can say it's a risk factor of the coronary obstruction during TAVI procedure. So I think the most important is aneurysm dimension. If you're small aneurysm, something like less than 28, or with lower height of the coronary right or left main high, less than 10 millimeter, or maybe the leaflet is higher than the coronary originate. Maybe there will be increases of coronary obstruction during the TAVI procedure. I think this is important during our CT analysis. Like this case, actually, it's a BAV case. BAV case, which means for this type 1, actually the Basava is quite large. I think there is a low risk, and also the coronary high is more than 15. So for this case, there is quite a low risk of coronary obstruction.
Thank you. Before procedure, my last question is, I noticed that the ECG is only, heart rate is only 45, and baseline ECG showed atrial fibrillation and IVB. How do you reduce the risk of permanent pacemaker implantation after TAVI procedure?
Actually, it's also a very important question. We all know the RBVB, right bundle branch block, is independent risk of pacemaker implantation after TAVI procedure. So from this case, I think how to avoid pacemaker implantation? I think the only one thing we can do is to higher implantation of the valve. To avoid the valve deployed extending the septal memory, which if we deploy the little too deep, maybe where compress the left band broach, which will result a 3-degree AV block after TAVI procedure. So from this case, I think thanks for its type of BAV case, we can do the high implantation, avoiding touch, avoiding exceed the septal brain, avoiding touch compress the left bundle branch. So this is my strategy.
Thank you. Thank you for your great experience. I noticed you have finished several steps. Please introduce your procedure step by step in detail. Thank you.
Okay. For this typical case, we still use a femoral approach. We insert the 20 French the sheath. And what we have done, let me show you. Actually, we have inserted the temporary pacemaker wire from the right jungle veins. And also we have successfully crossed the wire into the LV and explain with the pigtail. You can see the pigtail is in the LV and another pigtail in the aortic loop. From the hemodynamic, you can see there is a high gradient between the LV and the aortic loop, nearly 90 millimeter mercury. So it's a typical severe aortic stenosis. So I think next step I will insert my guard wire. It's a super stiff Landquest wire, which will give us more support. So we have shaped wire tip, make it double curve. Actually, from the echo, there is a hypertrophic of the LV, so which means left ventricular is smaller. So considering from the baseline, the echocardiography, there is a very little regurgitation. So maybe we should be cautious after balloon dilation. There will be a risk of the cardiac collapse. So we will, in order to avoid this, we should set up our valve. So according to the CT analysis, we decided to use 26. So the valve is already another method to avoid prevent the collapse after balloon dilation. I think we should use enough hydration for this case. So actually, you can see the baseline left ventricular diastolic end pressure is not. It is I think is you can see from the hemodynamic it's 23, so it's a little high. So that's okay for this. So Dr. Zhang Jian, can you introduce the baseline TTE of this case after general anesthesia?
Okay, Prof. Can you see my screen? Actually, you have thoroughly introduced the situation of echo of this patient. But one point, echo want to
Can
point.
you show the echo?
Okay. So actually, one point does echo want to point out is that this is typically bicuspid aortic valve, and there is no regurgitation, and there is a lot of calcification in the leaflet wall. So if there is peak, that means after the valve deployment, there is paravalvular leak, and the leakage, the regurgitation, the hypertrophic airway cannot long-standing tolerance volume overload because of the quiet hypertrophy and decreased airway filling. So maybe after, if there is more than mild PVR, I mean regurgitation leak, paravalvular leak, may decrease the long-standing survival of this patient. So I think this is one challenging for this patient, Prof. Yeah.
Okay, thank you. Actually, thank you for your introduction for the TT. So as this now you can see I input advanced the 20 millimeter balloon just across over the aortic stenosis. So So at this time, I will do the rapid pacing with high 118. So then do the predilation. So 118 pacing. Okay, rapid pacing. The BP decreased, maybe to still a little high. Okay, good. Okay, a little sleep. Down. Stop pacing. Okay. Okay. We have successfully do the balloon dilation with a 20 millimeter balloon. After that, we will do the TAVI for this case. We have set up a 26 venous A valve. It's a self-expand valve. This valve is domestic, and also we have more than 5 years result show the durability of this valve, especially for severe calcified and the BAV cases.
Professor, I have a question. I noticed after predilation, the hemodynamic is stable. And how do you select the valve size for this specific BIV patient? According to annular parameter or according based on the supraannular sizing?
So I think for this case, actually in China, we have a supraannular sizing case. But for this typical case, actually, it's a not so severe calcification. So this case, I sizing according to the annular diameter. The annular diameter is 23. So for this case, I will select the 26 valve.
Okay, thank you for your great experience.
Okay, then go to the LAO. Okay. You see there is a little resistance when we cross the valve. So we try again. Okay, we successfully cross the valve. It's not so easy, but when I ask my my Dr. Kung to pull back a little, then facilitate the valve cross, facilitate the TAVI system cross the aortic valve. So I think maybe we should use another projection, maybe LAO 30, cranial 60. Maybe this view can separate the left and the right corner. 第一个
伸床，床往上伸。
So the valve deploy projection is very important for TAVI procedure. Okay, good. Let's take a semi for this case. 3个点要成一条线，先照给你。This is good. Okay, from this view, we can separate this bicuspid valve. So for this typical case, I will do the high implantation, avoid the risk of the pacemaker implantation. Okay, then we go to the AP caudal view. Caudal 13 with the LA 1 degree. And to make the wire, advance the wire. Yeah, good. Very nice. Very good. Then still go to the LAO 30 degree, cranial 70.
What's the one? What's the one?
调成一条切线，把它给倒过来。 针点床，针点床，
跟气头。
针点鸡腿。OK, good， 太大了，OK, release, deploy the valve. During deploy valve, I will do the pacemaker pacing. OK, 120. OK, 噪音。OK, good. OK, release. 114. Oh, a little. Yes, please. You can see the position is good. Release. Release. OK, 到回收位了吗？
到了。
OK, stop pacing. Then we check the position to see is this a good position. 噪音机。I think it's good. What do you see? Can you go to the what level, the baseline of the map? Yeah, it's good. Yes, it's good. Good. Very nice. Okay, good. Okay, good. So we put the button of the aortic the TAVI procedure at the same level. Then we evaluate, do the CD again to confirm the position is good. And you see at this time the BP is good. I think a little high. What do you see? I think it's good.
Good.
This is what we like position. So at this time, I will try to release the valve. Then hold the wire. Yeah, hold the wire. We will hold the wire. Okay, good. At this time, I will push the whole system a little because it's high deployed. And do a task again. Yes. Good. It's good. Okay, one pacing. 114. 准备释放。Gently released. Okay, nice. Okay, good. Stop pacing. Wait, follow. Yeah. We pull out the whole system. Okay. Retrieve the whole system. Then we evaluate again. I think the position is good. Exchange with the pigtail. Facing to 70 degree. 70 BPM. Yeah, good. So next step, I think the position is good. Then we will exchange with the pigtail to evaluate the gradient. Then I will do a cine of the aortic root angiogram to evaluate the PVR degree.
Professor?
So I insert the pigtail into the IV. Go ahead, Dr. Gao.
Yes, a very good position. Yeah, TAVI master and a very good position. And how do you reduce the jumping out risk and how to reduce the diving into the ARV during the TAVI procedure?
Yeah,
What's your suggestion?
Yeah, I think it's a collaboration, teamwork during the TAVI procedure. So during deployed, I think we'll do the high speed, maybe like 120 to 140 pacing to stabilize the valve during the deployed, and evaluate with angiogram. And also, this is a typical BAV case, and also a high risk of the pacemaker implantation due to the baseline ECG RBVB. So our implantation degree, I think my intention is a high degree, maybe 0, just at the level of the annular. So thanks, it's a BAV case. The superior aortic root system can anchor in this valve. So this is my strategy. So you can see after we check the position, we pull a retro, the guard wire, and advance the whole system to the aortic root of the big curve. So make the valve system more coaxial during the final deployed, avoiding the valve jumping out. So you can see from the hemodynamic, actually there is no any gradient after valve implantation. So maybe we can take a aortic root angiogram to evaluate the PVR system. So just give me the wire. Dr. Zhang Juan, can you evaluate the echo to see the? Okay, good. 张念成。可以降，适当降一点血压。So can you explain the echo result after valve implantation?
So I think it is an excellent result, Prof. And the valve location is stable and the valve function is normal. There's almost no perivalvular regurgitation. And there's some central regurgitation, maybe because due to the catheter. The gradient, the transaortic valve velocity max is about 1.8 meter per second, and the peak pressure gradient is 14 meter mercury, and the mean get the mean pressure gradient.
It looks good.
Yes.
From the echocardiographer.
The mean pressure gradient is only 5.
Okay, good.
Meter mercury. Yeah. The airway function is normal.
Good. No PVR?
No PVR.
The valve position is excellent.
Yes.
I think so.
Mm.
That is a little, I think, central regurgitation.
Yeah.
That is a little PVR, what do you think? In the posterior side, do you think?
Yes, maybe posterior direction.
Okay.
Mild.
Mild. Okay, good.
But I think the regurgitation
is central or the PVR?
Is in the frame.
Oh, so it's essential, maybe due to
yes.
The pigtail cassette.
Yes.
Okay, good. Let me check the position. Okay, 打到。Okay, good. Sorry.
Mild.
It's mild regurgitation.
Professor, based on the final angio, do you plan to perform dilation? And what's the percentage of dilation in your daily practice for BAV patients?
So for this case, I think it's a mild regurgitation, and also there is no gradient. For this case, I will not do the post dilation for this case. If there is a gradient and also there is a high velocity more than 2 or 2.5 millimeter, maybe especially for BAV case with severe calcification, I will do the post dilation. Let's go to another view, IO caudal view. Evaluate again. Yeah. Okay, good.
And the patient is already 87 years old. Yeah.
I think the results good. What do you think? And the BP hemodynamic systolic is 186 and diastolic is 81. And there is a mild regurgitation, and also echo shows the position is good. The maximum velocity of the valve is only 1.4. So I think the result good. So if everybody agree, I will finish the case.
Okay, thank you. It's a very great case. And my final question is for this specific 87-year-old gentleman after TAVI procedure, what's your antithrombotic strategy for this patient?
For this case, it's I think it's a typical atrial fibrillation. So I will use a NOAC. For this case, I will use levasaban, 50 milligram per day for this case.
Okay, thank you. Thank you for your great case, and thank you for your sharing us with us about your great experience. And Professor, please summarize this case.
Yeah, so today actually, let me give a summary for this typical elderly patient presented with heart failure and chest pain, and echocardiography is a typical type 1 BAV case with a severe aortic stenosis. Considering the ECG is atrial fibrillation with right bundle branch block. So this is a high risk factor of the pacemaker implantation after TAVI procedure. So from the CT analysis, the member ring, the septal member only 2 millimeter. So in order to prevent pacemaker implantation, I will perform the valve implantation with a high degree, just at the aneurysm level. So during the valve implantation, so I think I will use LAO cranial view to separate these two leaflet, left and right leaflet, with 120 to 40 pacing. We carefully deploy the valve and do the senior to evaluate the valve depth. So final results show you it's a good deployed valve position, or maybe only 2 millimeter. And can you stop the pacing? Let me say the ECG pacing, stop pacing. So you see, actually, it's still the baseline. The ECG is still the atrial fibrillation with right bundle branch. There is no 3-degree AV block. So I think it's due to the high implantation. So it's good.
Yes, congratulations. Very great case.
I think that there is some questions from the online. We can answer these questions. The first one is how does the procedure approach for TAVI different in patient with a severe bicuspid valve stenosis compared with a tricuspid? I think in terms of the process approach, actually there is no difference. I think nowadays, globally, even in China, I think most of cases we will do the femoral approach in terms of the safety concerns. I think a rare case there is a very difficult peripheral artery approach. We will use something subclavian or carotid approach. But for this case, I think femoral approach is the first choice. The second question is what are the potential complication and the long-term outcome associated with TAVI patients with severe bicuspid valve stenosis? So far, according to the data published, I think compared with the tricuspid valve, bicuspid valve aortic stenosis after the TAVI procedure, I think long-term result is very similar. But for me, if the case is a complaint with severe calcification, if the case is like the valve is underdeployed and also the velocity is high or mean gravity is high after TAVI procedure, maybe I will concern the durability. But so far there is no longer long-term data. So we still with long-term data at least 5 or 10 years. The third question is what company designed the current valve you are used? Why do you choose that specialist valve? I think the venous A valve is the first self-expanded valve approved in China. And this valve, I think there is a server future, especially for BAV case. The radial force is quite strong, especially for this kind of a BAV with a severe calcified case. And I think, and another important thing is not only the good, very strong radial force, but also the crossability is quite good. You can see for this typical calcification BAV case after balloon dilation, the valve there is no any resistance when cross the valve. So for this case, especially for severe calcification BAV case, I think venous A valve is a very good choice. The third question, the first question is what percentage of the TAVI cases in China are performed with venous A? Personally, I don't know the detailed information. Maybe more than 1/3, I think at least. The last question is what are the key considerations and challenging in perform transcatheter aortic valve implantation for patients with severe cuspid valve stenosis? I think the first thing is valve, I think valve sizing, especially for severe calcification with BAV cases. Sometimes actually there will be difficulty to fully expand the valve. So at this time, if there is potential for under-expansion, maybe we will downsize the valve. We were sizing according to the superior architect, not only from the aneurysm. So I think most of the thing is sizing. So, and also another important technical issue is deployed. During deployed, I think the super stiff wire is very important because if there is severe calcification during deployed, the valve maybe there will easily prone to diving into the LV. So at this time, we should use a super stiff wire like Lundquist wire, and also the system, the operator assistant should hold maybe a little push the wire, avoid the valve diving into the LV. So that's all. Thanks for your attention. So today we do a good result live demonstration of the TAVI procedure for severe calcification BAV stenosis cases. Thank you. Go to pacemaker to